Bismillahirrahmanirrahim. We know that the pituitary gland is the master gland of the body, and itself it is divided into anterior pituitary and posterior pituitary. The anterior pituitary is also known as the adenohypophysis, while the posterior pituitary gland is known as the neurohypophysis. The hypothalamus secretes stimulatory or inhibitory factors that are carried in the blood by the hypothalamic pituitary hypophyseal circulation into the anterior pituitary gland, where they stimulate various populations of cells known as the Trop cells and cause the release of various hormones that uh, go in the blood and exert their effects on different glands throughout the body. For example, the thyroid stimulating hormone will have its action on thyroid gland. The adrenocorticotropic hormone, which is produced by the adrenocorticotrop cells, it will have its effect on the adrenal gland, and so on. The posterior pituitary gland actually itself it doesn't produce any hormone, and these are the neurons located in the hypothalamus, particularly the supraoptic nuclei and paraventricular nuclei, where the neurons produce hormones, and the two major hormones are the antidiuretic hormone or vasopressin and the oxytocin. These hormones are released by the axon terminals in the posterior pituitary gland, and they are stored here, and when needed upon signaling, these hormones are released into the blood. The antidiuretic hormone has got its action on the kidneys, while the oxytocin has got its action on the female pregnant uterus as well as the breasts or mammary glands. Clinically, the importance of oxytocin is less as compared to the antidiuretic hormone or vasopressin, because it has got timely and limited actions. During childbirth, it stimulates the contractions of the uterine myometrium and facilitates the birth of the child. While during the lactation period, it causes and stimulates contraction of the myoepithelial cells or muscles that surround the lactiferous ducts of the breast tissue or mammary glands and help in the ejection of milk. The antidiuretic hormone has got its action on the kidney, especially on the distal convoluted tubules and the collecting ducts, where specialized cells are located known as the principal cells. And these cells have in their cytoplasm vesicles that contain the protein aquaporins. The antidiuretic hormone binds to its receptor in these cells, and the ADH and receptor complex causes the vesicles that contain the protein aquaporin to move to the apical or luminal surface of the cells. Here, the ADH causes opening of the aquaporin channels, and water present in the urine running in the tubule is reabsorbed into these cells and is returned to the blood. Additionally, the antidiuretic hormone causes moderate type of vasoconstriction in the blood vessels, and by making the blood vessels lumen narrow, it increases the blood pressure. Now, the stimuli for antidiuretic hormone particularly includes the increased plasma colloidal osmotic pressure when the water content is less, also known as the oncotic pressure, distension of the left heart, and exercise and some emotional states may also stimulate the synthesis of the antidiuretic hormone. The two disorders of the posterior pituitary gland more common are the diabetes insipidus, in which there is decreased or no secretion of the antidiuretic hormone. As a result, there is no reabsorption of water. More water is passed in urine. That leads to large amounts of dilute urine, and patient may pass up to 3 liters of dilute urines per day. Here what happens that the water content of the serum is decreased, and as a result the increased content of the solutes in the serum makes the serum hypertonic and the osmolarity of the serum is increased. While going more water in the urine, the osmolarity of the urine is decreased. Now coming to the causes of the inappropriate or excess antidiuretic hormone secretions, there are intracranial causes in which there is injury to the hypothalamus or posterior pituitary gland that may be caused by trauma, accidents, head injuries, and sometimes neurosurgery, where unintentional or iatrogenic damage occurs. And the extracranial causes that cause oversecretion of the antidiuretic hormone includes the ectopic ADH secretion by certain malignant tumors like small cell carcinoma of the lung, carcinoma of the stomach, and carcinoma of the duodenum. In ectopic ADH secretion, there is no pathology in the posterior pituitary gland or hypothalamus, but the antidiuretic hormone is coming from an ectopic site. Additionally, there are some neoplastic, non-neoplastic lung diseases. For example, infections in the form of COPD, pneumonia, and asthma, in which the conditions in which the ADH secretion is increased. A number of drugs may cause increased secretion of ADH, particularly, for example, ciprofloxacin and valproic acid. Ciprofloxacin is an antibiotic, and valproic acid is a drug that is used in neurological conditions like epilepsy and other conditions. They also lead to an increased secretion of the antidiuretic hormone. So what happens that the antidiuretic hormone acts on the principal cells of the distal convoluted tubules and collecting ducts, and here it increases the reabsorption of water from the urine. So when the water content of the blood is increased, comparatively the sodium content is less in comparison to the water content, and as a result the sodium concentration in the serum is decreased, and less sodium concentration will lead to the hyponatremia. We know that increased concentration of sodium inside the cells compared to the decreased concentration of sodium in the extracellular space will pull water into the cells from the extracellular space, and this transfer of water from the extracellular space to the intracellular space, which is caused by the sodium concentration gradient or difference, will lead to cerebral edema, and it can lead to potentially serious neurological manifestations like confusion, hallucinations, and even sometimes it may be lethal and can cause death. The pathophysiology of the syndrome of inappropriate ADH secretion starts with the excess and uncontrolled antidiuretic hormone secretion. Now, this antidiuretic hormone secretion binds to its receptors on the principal cells of the collecting ducts and causes the aquaporine channels on the luminal surface of the cells to open and the entry of water from the urine into the cells and ultimately which is returned into the blood. So the excess presence of water compared to the sodium will cause a decrease in the serum osmolarity, while at the same time when more water is reabsorbed from the urine osmolarity will be increased. It will contain more solutes as compared to the water content. Now, the increased reabsorption of water will increase the blood volume, and receptors located in the heart and blood vessels known as the natriuretic peptides, like atrial natriuretic peptide and brain natriuretic peptide. These natriuretic peptides are released from the heart and blood vessels, and they will inhibit the renin-angiotensin-aldosterone mechanism. We know that renin, which is secreted by the juxtaglomerular apparatus of the kidney, nephron, it converts in angiotensinogen into angiotensin 1. The angiotensin 1 carried into the lung is converted by the angiotensin converting enzymes or ACE enzymes into angiotensin 2, and the angiotensin 2 then cause secretion of aldosterone from the zona glomerulosa portion of the adrenal cortex, and this aldosterone then increases the reabsorption of sodium followed by water. Now, the natriuretic peptides, they will inhibit aldosterone or aldosterone absorbed reabsorption of sodium. So as a result, what will happen that when aldosterone is inhibited, there is no reabsorption of sodium, and this will lead to increased sodium excretion in the urine. And as we know that the sodium will pull water after it, so at the end what happens that there is increased excretion of the sodium, the condition which is known as the natriuresis. As a result of this inhibition, which is a compensatory mechanism, the ADH induced increase in the blood volume will be decreased, because inhibition of aldosterone will cause increased sodium excretion followed by water. But at the end of this exercise, what happens? That the blood volume may return to normal, but at the expense of loss of sodium. And when sodium is lost, the serum concentration of sodium is decreased, and this condition is known as the hyponatremia with its downward complications and consequences. Now, two things occur in syndrome of inappropriate ADH secretion or excess ADH secretion. Due to increase of water content in the blood, the sodium is diluted. As a result, the osmolarity of the blood is decreased and the blood becomes more hypoosmolar and more hypotonic. And additionally, inhibition of the renin angiotensin aldosterone mechanism, there is loss of sodium in the urine. And this will lead to hyponatremia. Now, what happens that what occurs during dehydration. In dehydration, also water is lost from the body, and as a result, the sodium concentration is decreased, leading to symptoms like headache, nausea, vomiting in acute conditions, and there may be associated muscle cramps and tremors. But the mechanisms of dehydration and syndrome of inappropriate ADH secretions, they are different. In dehydration, water and sodium are lost, while in inappropriate ADH secretion or excess ADH secretion, there is an increase in the blood volume and comparatively the solutes concentration is less as compared to the water content. Moreover, the inhibition of the aldosterone induced sodium reabsorption, more sodium is lost in the urine. If the condition becomes chronic, what happens that the increased sodium concentration in the neurons as compared to the decreased sodium concentration in the extracellular fluid, they will pull water into the glial cells of the central nervous system, and this will lead to swelling and cerebral edema. And this cerebral edema may cause serious symptoms like confusion, swings in the mood, hallucinations, seizures, can lead to coma and sometimes to death. Now, how do we diagnose SIADH? We listen to the patient, we examine the signs and symptoms, and then we do certain lab tests. What we expect in SIADH, that the excessive reabsorption of water will cause an increase in the water content of the serum, and comparatively the solute content is less, so the sodium concentration is decreased, and as a result the plasma osmolarity is decreased in SIADH, in contrast to diabetes insipidus, in which the plasma osmolarity is increased. Now, if we look at the urine, what happens that water is reabsorbed by the ADH. There is less water in the urine. As a result, the concentration of sodium is increased and the urine becomes hyperosmolar. The osmolarity of the urine is increased. Now, in this slide, here we can see in my previous lecture, I explained the molarity and molality, and I told you that these are the nearly the same things, but the difference lies in the expression. In molarity, we take the volume, the number of moles of solute per liter of the solution, while in the molality, we take the weight, the number of moles of solute per kilogram of the solvent. And when we say osmolarity and osmolarity, this means that 1 mole contain 1000 milliosmoles. And then will be expressed in milliosmoles per liter or milliosmoles per kilogram. Usually, the osmolarity is used in the labs, while in medical and clinical language, we talk about the osmolality, milliosmoles per kilogram of the solvent, expression by weight. Now, if you see at this solution, there is a balanced solution of the solutes and balanced concentration of water. So we say that this is isoosmolar. But here what happens that the water content is increased as that what happens in the SiADH. Comparatively, the solute concentration is less and this solution is known as the hypoosmolar. While in contrast to SiADH in diabetes insipidus, what happens that water is lost in the urine, the water content of the blood is lost and the solute concentration is increased, and we say this is hyperosmolar solution. So in the syndrome of inappropriate ADH secretion, the urine will contain more solutes because water is reabsorbed by the excess ADH, and this will give rise to increased osmolality of the urine. While when water is added to the serum, its concentration, the concentration of solutes as compared to water is decreased, and the overall the osmolality of the serum is decreased due to excess reabsorption of water. Now, if we compare these to diabetes insipidus, which is a common question that is asked, that what is the difference between the diabetes insipidus and syndrome of inappropriate ADH secretion. So here in diabetes insipidus, the urine will contain more water as there is no ADH and dilute urine is excreted. Comparatively, the blood concentration of the solutes is increased as water is lost. So the plasma will show increased osmolality. And in the SiADH, what happens that excess secretion of antidiuretic hormone causes reabsorption of water. The urine content of water is decreased while the serum content of the water is increased. Here we compare the lab investigations of diabetes insipidus and SiADH. Normally, the serum osmolality is in between 285 to 295 milliosmoles per kg. By that we mean that it is less than 300 milliosmoles or millimoles. While the urine osmolality is 500 to 800 millimoles or milliosmoles per kg, and it should be more than 800 milliosmoles per kg. Now, what happens in diabetes insipidus? That lack of ADH causes excretion of dilute and more urine. As a result of this, the water content of the serum is decreased and the solute content concentration is increased, and the serum becomes hypertonic. Similarly, the sodium concentration of the serum is increased due to loss of water, and this will turn the solution hypertonic. Now, coming to the urine, excess water is excreted due to lack of antidiuretic hormone, and the osmolarity is less than 300. By that we mean contains more water and less solutes. But in SIADH there is a complete opposite to the diabetes insipidus. More water is reabsorbed by the excess ADH from the distal convoluted tubules and collecting ducts, and as a result the solute concentration compared to the water content is decreased. And as a result of the presence of more water and less solutes, the osmolality of the serum is decreased. Similarly, the serum sodium concentration is decreased due to the presence of more water, and the serum becomes hypotonic. Here it was hypertonic due to excess sodium, but here due to less sodium it becomes hypotonic. Coming to the urine, in diabetes insipidus, the urine contained lot of water and less solutes, and the osmolality was less than 300. But in SIADH, the excess secretion of antidiuretic hormone, which increases the reabsorption of water from the urine, the solute concentration or sodium concentration of the urine is increased, and this will lead to increased osmolality. By that we mean that more than 800 milliosmoles per kg will be the osmolality, and the specific gravity of the urine is also increased. Now, simply comparing, in SIADH, the serum sodium concentration is decreased because of excess water as compared to sodium. The sodium osmolality is decreased, but due to reabsorption of water, less water is excreted in urine, and as a result the solute concentration is high and the urine osmolality is increased. While in diabetes insipidus, opposite will occur. Loss of water will lead to excess concentration of sodium and solutes, and the serum sodium concentration will be increased. As a result, the serum osmolality is increased, and due to excess loss of water, the osmolality of the urine is decreased. While in simple dehydration, the is compared to SIADH and diabetes insipidus, in simple dehydration, the urine osmolality is increased, unlike the diabetes insipidus, in which more water is passed, but here there is less water. Similarly, in dehydration, due to less water, the serum sodium concentration is increased. This will lead to increased serum osmolality. But here, the urine osmolality will be increased because there is little water and excess solutes. And these three conditions comes in the differential diagnosis and they should be distinguished. Now coming to the treatment of the SIADH, the underlying cause should be treated. If there is injury to pituitary, if there is injury to hypothalamus, so whatever is appropriate, it should be done. But we should restrict daily fluid intake because due to the presence of antidiuretic hormone, there will be excess reabsorption of water from the urine flowing in the distal convoluted tubules and collecting ducts, and by decreasing the intake of water we try to make a balance. Since sodium is lost, so the diet of the patient of SIADH should have high salt and high protein content. Some drugs that inhibit antidiuretic hormone and that act as antagonists are those that bind to the receptors of the ADH will inhibit the action of the ADH, excess ADH in SIADH, and they are helpful. But if we get a patient with severe antidiuretic hormone excess, then we may expect excess loss of sodium and the patient may be in hyponatremia, which has serious uh, consequences, particularly the central nervous system. Its effects on central nervous systems are concerned. So these patients should be treated on an emergency by administration of the intravenous hypertonic fluids to reduce the chance of cerebral edema and its uh, associated complications and consequences. Thank you very much.